All right, I'm back again, a little more tired. And again, aloha, I'm the traveling doctor, Dr. Albert Lin, delivering your COVID-19 daily update podcast. Again, I was trained at NYU for medical school, went to Cedars-Sinai for my internal medicine residency, and I'm a hospitalist practicing on Hawaii for the last 14 years. Was going to go into maybe a little bit not so detailed podcast today. I'm not going to go over all the, over-the-counter treatments, everything else. I think people are slowly joining me. Again, I apologize. It's 8 p.m. Hawaii Standard Time, so anyone who's watching the East Coast, you're probably watching this late. I was at work all today, which was part of something I want to discuss about what's looking like in the hospitals right now. So for me, I'm on day number 11 of social distancing and self-quarantining, but this was my first day going to work, and there was very little traffic, either going to work or coming back, which I'm sure some of you who are still working have seen that. Once again, I'm COVID-19 negative by that test. That's not the greatest test in the world. Again, I talked about this a little yesterday, or not yesterday, but Sunday, the low sensitivity of this test. The sensitivity is only about 70%. There's a high false negative rate. I'm still coughing a little bit, but supposedly I'm negative. And I'm going to go into some of the kind of optimizations and good news that we have regarding some of the other tests that are coming up soon. So hopefully we'll have a little bit better weapons and power to cut that. So again, technically I'm negative. I went into the hospital today. Luckily, we don't have anyone there yet. Hawaii, and I'll update you more later, we're up to 90 active cases, or actually 89, I guess, and 1 death. So we had 90 cases and 1 person died. The 1 person who died is, it's a little tricky because everyone wants to know who this person is and, what his name was or her name was and where they were, and did, me or my family touch them or get breathed on by them or anything. Honestly, I think we have to get over that idea, because this is not going to be the first death. We're going to have more. And again, what does it really change for you? I mean, you probably may want to know whether you get more initiative to get tested or not, but it won't really change how you feel right now physically. My point is this, that the guy who died, they found it after the fact. I looked into this. He died, and they didn't report it till, I think, today, but he was actually dead on Saturday. Yeah, so I think Stacy mentioned, he actually had, I think it was a he, I'm reading in between the lines from what they're saying, had multiple comorbidities, or was a sick person before. So again, I think the person died and they tested the person after the fact, and they found out that, oh, they had COVID-19. So did this person die of COVID-19, or did they die of whatever else they had, heart failure and kidney failure and other stuff? So yeah, Stacy said older guy, pre-existing conditions. So again, it's hard. Did he die from COVID-19? Did he die from something else? And I will go, the reason why that's important is that some people have been starting to play a little devil's advocate with me, including my friend Todd and my friend Bruce. Some people mentioned about, well, why don't we just quarantine all the really sick people and let everyone do their thing and get herd immunity? I'll go into that a little bit later, but I want to talk a little bit about what my day was like in the hospital. So I go in the hospital, and I'm seeing my normal patients, and I guess what was going on was, I'll tell you the one thing. I've worked for 14 years in many, many different hospitals in 5 or 6 different cities, public, private, big, small. And this hospital today, even though we don't have a single patient, the fear was palpable. I mean, what I mean by that is everyone was sort of on edge. We don't have anyone, but everyone was worried if someone was coming in, people wearing masks. In fact, because I was coughing, I wore my N95 mask because I was coughing, and I didn't want to get, in case I had anything, even if I had a common cold or whatever, I should protect myself. About an hour into my work shift, I get, a message from my admin and higher ups, basically saying you need to take your N95 mask off. And I'm sure, you know, you've heard some of these stories, and that kind of upset me for a little bit. And then, you know, what I was basically being told was that if I wear an N95 mask, I freak everyone out. I freak out the rest of the staff. I freak out the patients, and everyone thinks they need an N95 mask. And the truth was, I wanted to wear a normal mask, but guess what? We don't have any more normal masks in the hospital. We do have them, but they're being held and quarantined, so to speak, by staff. The staff are holding them, then, you know, the higher ups, and they're rationing them out. So, and I told my higher ups, I'm like, listen, I don't need to wear an N95 mask. I need to wear a mask because I'm coughing. So would you rather me walk around all day coughing in my elbow? Does that look safer for everybody? Or would you rather me have a mask? So like, okay, good point. So I'm like, well, give me a mask. But you see what I'm getting at? Like, it's sort of like I had to pull teeth to get a single surgical mask. And we have them, and I don't think we're running out yet, but that's kind of backwards, right? Like, in my mind, and I understand why if we were wearing masks all over the place, we'll run out of them. But all my nurse friends out there, who I have a few who are out there in healthcare, and doctors, everyone understands what I'm talking about. And again, in Banner Health System in Arizona, people were told to take their mask off, otherwise they'd be fired. I think some people in certain Kaisers were told this too. There's people who are all upset. I mean, basically because our frontline people are being treated kind of like we're cannon fodder. Like, we, you know, oh, don't do something because it'll freak people out. I mean, newsflash, everyone's freaked out already. If we want to protect not even ourselves, but protect our patients, because again, like I have a cough or something, you know, the problem is every hospital system has its own policy, kind of like the same way that the federal government is saying things and different state governments are doing different things. And it depends on whether one hospital, you know, has this boss that's worried about stuff, or, you know, and so I guess what I'm saying is it was a very unusual experience for me because I hadn't worked since this started getting really bad. And again, it's not really, really bad, but it will get bad. And if it's this bad right now, I'm sort of wondering how it's going to be later. So obviously I'm going to wear a mask. My supply is still coming in, but again, they're N95, I'm not supposed to be wearing those. We have our protocol about how we're going to deal with these patients as they come in. And I'll get to that later because it's really elaborate. It's really kind of scary how much detail is involved in doing a clean preparation of personal protective equipment for a real COVID-19 patient. And I've talked to some of my other friends. My friend David, who may be out there watching too, is an anesthesiologist, and he's most at risk. And a lot of doctors who work with intubating, and if you think about it, you're staring to someone's face and they're coughing at you or doing whatever, you're the one who's most likely going to get sick. And a lot of these doctors want some knowledge, and not even the doctors, respiratory therapists and nurses. So that's a little annoying for us. So that was my personal feeling right off the bat. Stefan also mentions some masks are from China. They're not hospital proof. That's another problem. Yeah. And Rowan also mentions, yeah, you know, and Amber, both people in healthcare, nurses, and everyone. So this is not an individual story. I'm trying to tell you, these stories that you see on Facebook, they are not like made up stories. This literally just happened to me. And yeah, it's sort of harmless, but is it really? Like after a while, it's not really that harmless. Stefan, so you bring up a good point. Over the last week, I've had a lot of helpful friends who've said, well, I have this supply chain and I have friends who can help you get some masks from China. You know, do you want to order a certain number, a couple hundred, a couple thousand, you know, a lot. And the problem is two things. Number one, I'm not in charge of supply. So as much as I would love to order these and it's emergency time, like the hospital purchaser has to order them, and they only order certain ones that are whatever approved. And, you know, they're also worried about a price point. A lot of the masks that come in from China through third-party suppliers, there's a big tick in the price because of the cost of shipping. I've heard about problems of shipments being held at the docks. There's always a chance, I'm not saying that it's any of my friends, but you know, it could be a scam thing. So it's always really hard because obviously the hospitals want to be prepared for you know, having surgical masks and N95 masks. Oh, Stefan, 50 pack. Yeah, that's good. That'd be great for a personal supply or whatever. But again, here's the problem. Number one, hospitals don't have an unlimited budget, so they can't spend all their money and they don't want to spend double their money. They want to spend it as they get it. And so many hospitals have such a limited budget that they're really struggling on what to do. Even if they want to buy an extra ventilator, some hospitals literally don't have money to buy an extra 5 ventilators, say they need it. They would literally need someone to donate it, or government or something. So, I won't go, obviously bigger hospitals and bigger hospital systems have more help with that. And New York is suffering greatly, which I'll get into, and they need a lot of ventilators, but I'll get into that. Also, Stefan, with the 50 pack, say even mine, like technically, if I brought in my own, I think that's where some hospital systems have been getting down on doctors and nurses. They're like, well, okay, you can wear N95 or you can wear a surgical mask, but you have to wear ours because we don't know how yours are. It's like yours are like handmade, or yours are not approved, or there's a liability issue because you brought it, you use it for toilet paper at home and now you're using it on your self as a mask. So they're looking at it from a very admin liability standpoint. And again, I understand why they're doing it, but it doesn't help people when the CDC is telling us, again, use bandanas and scarves, and then hospital admin is telling us, well, you can't use your own stuff. Well, which is it? Can you use your own stuff and stuff that's made, or can you not? There's a lot of mixed messages. And again, if you talk to one nurse and one doctor, one hospital will be very different from the other hospital. Lisa asked about community donations. We're starting it up in Hawaii. It is better. We're starting up some drives. The big hospital system here, Queens Medical Center, they actually put a plea out in the Honolulu Advertiser to ask for donations. And I think the donations will be unopened, legit boxes that will go directly to the supervisor. And that's why I'm saying, that would be the best thing, either handing a friend, obviously, that works with it directly, some of those, but handing it directly to the nurse supervisor or whoever's in charge of the equipment, because then they can ration them out logistically and realistically. Stacy says Ford, GM, and Tesla are going to try to make ventilators. Ford is getting into, from what I'm hearing, some of these businesses are getting into the ventilator business. Tesla, actually, I thought it was funny. I thought Tesla was actually making them. Turns out it sounds like they bought 1,500 from China because they're a leftover, because China's getting over needing ventilators, and he just shipped them to California. So Tesla didn't make theirs. Elon Musk was just kind of a little bit of a, went around behind the scenes, not really jokes, are very helpful and helped out California. Now, California got 1,500 from Tesla. New York, again, New York's getting whomped on. I'll get to that later. So, one thing I did want to mention about the testing, again, there are new CDC guidelines coming out all the time. By the end of the week, supposedly they'll have anything from a very fast, rapid 45-minute test. I've even heard that they're working on a 10-minute test. I mean, it's great if we get these tests. But again, the test I really want is that antibody IgM, IgG test. That test that tells you if you've been infected or not. And this is not just to know whether someone like me is infected or was infected, or if anyone else is. There's a legitimate societal reason why we need to know about IgM, IgG, besides it can be done quicker. It has a lot to do about the rollout of when people can go back to work, and it also has a lot to do with possibly using some of that information for a vaccine and stuff like that, So Rowan says, yeah, so Tesla, I think they will start making them. Elon Musk is a genius. So the point is, certain companies can be used for manufacturing heavy equipment, and certain ones can be used for manufacturing masks. And and obviously some of the car companies can do heavy machinery, but they can't do masks. That just makes sense, right? And like the alcohol companies, distilleries can make the alcohol for the hand sanitizer, but again, they can't make masks or ventilators. The people that can make masks that were maybe making some sort of fabric or other things can make that. But again, I think that's part of the complication also with Trump and the federal government response. And I'm not going to get political again. This is not supposed to be a political thing, but that's part of the problem. You cannot just tell companies, in some ways he's right. You can't just say, hey, Milton Bradley, you guys make board games. Why don't you just start making masks? It doesn't work that way. It's going to be kind of useless, if you tell the wrong company to make the wrong thing. So there is a learning process to it. Unfortunately, it's not going by quick enough. So that's enough about the antibody test. And I'll tell you also why it'll be important later as I go into suggestions. So again, and I want to reiterate some of these tips about keeping clean. As I mentioned yesterday, no gym, or last podcast, don't go to gym. Don't hang on to, equipment that people are doing. anything that people are touching out in public. This goes into delivery. You know, if everyone's getting delivery, and, you know, I personally would rather, I've been cooking a lot or taking out. I mean, you don't have to be a hypochondriac about it, but it just makes a lot of sense, you know? All these people lining up at Costco and the groceries are not really, again, practicing social distancing. My friend from Australia and other countries are saying they're actually doing like Handmaid's Tale type social distancing. When you get in line in a queue, they actually have tape marked off, so you're 1.5 meters or 6 feet away from someone. Think about it. If you're all right in line, jammed in, using your self-checkout and doing everything else, you're not really social distancing too. They actually have monitors at Australia telling you, like Handmaid's Tale style, like keep away from that person, keep away from that person. I mean, it's kind of funny, it's kind of, you know, morbid, but it is something that's needed. And I'm telling you, it's not happening in Hawaii. People are still lining up at 6 a.m. every day at Target and Costco to get toilet paper and Spam and towels and more toilet paper. And I'm like, guys, seriously, like, this is not, I mean, you can social distance every other way, but if every day you decide to go into a market and line up right next to somebody in a big market. Oh, that's my other tip. Don't go to the big markets. Go to the smaller markets. Don't go to these mega stores, the Walmarts, the Costco's, whatever. If you go to the smaller places, a lot more likely someone will not be. There's smaller grocery stores. You may be luckier in terms of what you get. And again, don't hoard, and I'll get into why that's important. Oh, one thing I want to mention, and this goes into keeping clean, and this is a really sort of sad statistics. Oh, Walgreens has tape on the floor. That's good to know, Rowan. I'm going to go to Walgreens at some point. And Lisa would bring a ski pole. Okay, Lisa, that's great. Hopefully you don't actually jab someone with it. But Trader Joe's has tape on the floor. Okay, that's good. Well, I think, again, retail people are starting to learn as probably people start to complain. But here's a scary statistic. Did you guys hear about all the Carnival cruises and how much, you know, you've been hearing about it stays, coronavirus, COVID-19 stays on cardboard for a day. It stays on plastic and metal for 2 or 3 days. Well, they've been finding out on these Carnival cruises that they cleared out of all the old, sick, dead people, whatever, and got everyone else off. They went back a couple of days later. By a couple of days later, I mean 2 weeks later, in fact, 17 days later, and they were still finding COVID-19 on some of those rooms that had been not occupied for 17 days. My point is, this has to make you think and change your idea about how long something can stay, COVID can stay on something. I mean, you should clean. You should clean all the time. I mean, you don't need to be ridiculous about it, but the point is you can't just assume something's clean, you know, especially, I've heard stories about ER doctors literally going back to their apartments in New York, stripping naked, no joke, in the hallway, putting their, you know, clothes in a bag, not hugging their family, keeping their shoes outside the door, going in to shower and then hanging out with their family, you know, keeping, again, clean sneakers just for going home, and clean scrubs and or clean clothes for going home. These are all things that are very important. So good. It's good to hear that everyone's saying Whole Foods, Trader Joe's, different places, Walgreens are having tape on the floor. That's really, really good. Stacy says, could it infect after that long? Again, that's hard to say. It's on there. Same way that if someone is virulent and has shedding of COVID-19, does that mean they've actually infected someone? That's hard to say. I mean, personally, at this point, I would rather them clean it and, you know later. And again, I'll go into that about herd immunity and whether COVID is actually the antichrist that we think it is, or there are other ways that we can deal with it. Because, you know, I'm starting to think that, you know, as some of you may think, there's got to be an endpoint to this. Not like Trump, like let's open it up in 7 days endpoint, but there has to be some sort of logical endpoint. I'll tell you my thoughts later. April May Taylor, her husband stripped naked at the door after removing his shoes and plastic. That's good. How many masks should individual keep so we know how many to donate? Well, you know, I think, again, you know, as you see doctors are trying to get their N95s, even normal surgical masks, what I would say is I would portion out a mask for, you know, every time that you're going out that you know you're going to be in a crowded area where you would worry that you would be very close to somebody, you know? And ideally, those are single use. Can you use them more than once? Yeah, especially if you're not coughing. You know, it's touching the mask a lot. Again, touching the mask, coughing on the mask, getting it wet, are not easy ways to keep it clean, and then you pretty much have to toss it. So I would say keep as many as you think you need for, let's say, a 3 to 4 month period. Say you're going out, like, let's say, 3 times a week, which I think is a lot to be going out to crowded areas 3 times a week if you're really practicing self-distancing. So say you're keeping 12 or 15 a month, then in 3 months you're keeping what, 45 or something, like, I think that would be adequate if between you and your partner or friends or whatever. I mean, I think having like 40, a box of 40 or 50 will probably, if you portion it out the right way, last you. Because again, if you don't leave your place and you clean your place and you're clean around your people and your family and your friends, do you really need masks around your family? No, you only really need it when you're going out in a crowded environment. And now that brings me into cleaning stuff. Greg, okay, I'm gonna answer that a little bit later, but I wanna finish up about cleaning masks. So cleaning masks, now again, the CDC gave this brilliant, like, it sounds really funny information that you can clean a mask, an N95 mask, by putting it at 140 degrees Celsius or something like that in an oven for like 30 minutes. That's brilliant. Let me just go to my, little oven in the hospital and bake my mask for 30 minutes and then use it again. I mean, this is one of those things that sounds awesome until you realize it's completely impractical and means nothing for people. We cannot bake our mask when someone is crashing on the floor and we need the mask right now. We can't bake our mask. And even if we baked our mask, then it's burning hot and there's metal in it and we need it to cool down. So, it's great that we can sterilize stuff by baking it, but that's not a really good alternative. So Greg also asked about the spread of the virus in Southern Hemisphere winter, Australia, smaller population, density slowing down the speed. Good points, and I'm gonna get into that a little bit. A lot of people ask about the temperature effect. I really don't, oh yeah, Stacy, that is a good idea. I've heard one good way. You can add it, as long as you think it's clean, on the window dash and the sun will bake it. That is one decent way. If I were really limited, that'd be a way I personally would do it, because it does get hot in my car for sure. There's no guarantee, but it's better than not cleaning it and having to reuse it and it not being clean. And again, the important thing is you do not touch the front of the mask. You do not touch the front of the mask. You hang it, even how you take it off, you're supposed to take it off over the top of your head. And I may not be able to demonstrate it, but you can YouTube donning and doffing PPE on YouTube. Donning and doffing PPE. It's pretty complicated when you get all this stuff with hairnets and masks and gloves and everything else. Microwave, well, Rowan, I mean, microwave may be difficult because, again, there's metal in there. I don't think I would microwave an N95 with metal in it. That sounds a little dicey to me. I don't think you can microwave it. I don't think bleach works. From what I heard, it'll destroy certain parts of the porousness. And UV light, I've heard mixed things. I heard some people are using CPAP machine cleaners. And again, this is stupid we have to even go to this point, but we're talking about it. And again, getting back to Greg's point, what do I think about, I've addressed this many times in previous podcasts, does temperature affect it? There's a chance that it will, but again, I don't know. Again, we may see, again, as Southern Hemisphere goes into winter with Australia, and they're actually going into their flu season. Now, again, in America and the Northern Hemisphere, we're getting out of our flu season. So you would think maybe it's getting better for us as April goes away and May and June, summer heat starts burning in. But if you think about Australia and New Zealand, they're just going in to get their flu shots now. They're just going in. So there may be a weird effect where we start seeing a lot of Southern Hemisphere places. And that's what? That's a lot of places that haven't been hit too hard. Africa, South America, Australia, New Zealand. Have you remembered that all these Northern Hemisphere countries have been where it's been the biggest spread? There's another sort of like conspiracy theory about why, Africa has fewer cases. And I was trying to do this without jumping around, but I'll jump into this real quick, which is a lot of people think, oh, well, Africa has high instances of malaria, right? And what do people with malaria take? Does this sound familiar? Hydroxychloroquine and chloroquine in these malaria type treatments. So there's the idea that, oh, everyone in Africa has been so worried about malaria and taking it for that's why, because they've been self-treating with hydroxychloroquine. Even if they did get sick, they killed it with this hydroxychloroquine. And again, I've mentioned hydroxychloroquine a lot. By this point, you've been living under a rock if you haven't heard of it. And it's a problem for a couple reasons. Again, people are poisoning themselves on it. There's a guy in Australia and his wife who thought he can drink hydroxychloroquine and he drank aquarium cleaner. It's not, I mean, it's not necessarily Trump's fault, like Daniel Day Kim's fault, like anyone's fault, but everyone hears this and he thought, well, maybe I can drink literally aquarium cleaner. I don't know what type it was, but it had chloroquine or hydroxychloroquine in it or something. And guess what? The guy died, and his wife's in intensive care and might die. Not from COVID-19, but from hydroxychloroquine poisoning. So, and why this upsets me a little bit too is you'd think everyone would be smart about this, but my friend Veronica forwarded me an article that says doctors, they're seeing doctors in certain states, Kentucky, Texas, others, and this is horrible. I'm ashamed of these doctors that have been prescribing it to like their family members, friends, their own selves. You know, I think that's a shame. That is really, really a shame. It goes against do no harm in the Hippocratic Oath is what I think, because you're taking it out of the supply, and you take it out of the supply, someone down the line who may need it is not going to get it because there already is a shortage. So by definition, you're doing harm. Trust me, I've had my opportunity to potentially ask, you know, other doctors, family members to write it for me, and I won't do that because that's quite honestly, that's like ethics 101. I would hope that if I need it, it's going to be available. And again, I'm telling you to my friends out there, because I know someone after this is going to ask me, I will not write it for you. I'm only licensed in the state of Hawaii anyway. I will not write this prescription for you. I won't risk my license, and I won't risk my ethics on this. You know, even if it does work, we need to save it for the people who need it. Again, it's a Costco toilet paper hoarding thing, but this is about something that actually may have some health benefit, or may not, because they're doing some studies. Oh, I want to mention some of the studies. So I forgot to mention all these other tests that they're doing. There's this cool study I've heard of called the Solidarity Trial. The World Health Organization is enrolling people really quick. So when doctors get a COVID patient and we decide to try something, whether it's Kaletra, or again, the Remdesivir, or hydroxychloroquine or azithromycin, we can log into the Solidarity trial and say what the patient is, what they have, their age or whatever, and then we're basically crowdsourcing in real time the treatment. So we should get a good idea, not me so much because I haven't been taking care of so many, but a good comparison between Remdesivir and, you know, again, hydroxychloroquine and azithromycin. There's another one from Regeneron called Kevzara. There's one from Roche called Acetemra. And again, favipiravir from Fujifilm, and IVIG. There's plasma being drawn from people and antibodies, all of that stuff. They're trying to test everything, and this Solidarity trial will ideally give us answers much quicker than your typical trial. Again, look this up. I'm hopeful for the Solidarity trial. Again, it's an international trial as I understand it, and that's what's different from just looking from a tiny study like the hydroxychloroquine study was in France with, again, like 40 people. This is a massive international prospective kind of study. It's not really double blind because you're not giving people a choice in a placebo, but yeah. Okay, so another thing that someone mentioned to me, and I want to bring up some other stupid fake treatments. Again, every day there's a new fake treatment. Again, blow drying, I forget if I mentioned it, but blow drying in the hair dryer in the nose and mouth. Again, inactivating the virus, that won't work. Hot water, gargling, you know, stuff, that'll all make you maybe feel better, but it won't work. Asians love to drink hot water. They love to drink it all the time, even when it's hot. They love to drink hot tea. This is not going to kill the virus, so just don't think about that. The idea about herd immunity, someone brought that up. I think it was, again, my friend Todd and some others. And the idea of herd immunity is you get everyone exposed to it really quick. You don't, you know, quarantine people. Certain people get the, you know, antibodies and it's around, and, you know, then you don't worry too much. And some people will get sick, but they won't get sick at that same level as if they didn't have this exposure. And herd immunity has always been used for example for why you need to give everyone the measles vaccine. And anti-vaxxers are like, oh no, I don't want to, you know, I'm hiding my kids. And since they hid their kids, they weren't exposed to this sort of measles stuff, and especially with the measles vaccine. And then, you know, you start to get outbreaks of stuff and outbreaks of measles because this whole community of anti-vaxxers hasn't vaccinated their measles kid. So the idea is, can this work for COVID-19? I'll tell you, while theoretically can work, and initially I think even England was thinking they were going to do that, and a lot of people have been saying, hey, why don't we just hide all the old people, all the, over 70 years old, anyone with chronic conditions, immunocompromised, put them bubble boy status, hide them for a year or something, and let everyone just run around who will get sick a little bit, but won't really, be hard in terms of dying and bad rates. And then we keep the old people sick, and when they get sick, then we take care of them. The reason I think that's a bad idea is three reasons. Number one, people are looking at this binary. Oh, we just keep the old people and the immune compromised people, hidden, and then when they get sick, they go in with COVID-19. You guys, I think it's not binary. People who are old and sick from other stuff are going to need to come to the hospital because they're old and sick from other stuff. They were going to have kidney failure, heart failure, lung disease, and they're going to end up coming in the hospital. Even when you try to protect them from COVID-19, they're going to come in from something else. If you suddenly take this group and stuff them into a hospital that has had herd immunity, everything, it's going to be impossible to keep this clean. And that's why I think then the mortality rates, instead of being 15%, are going to go crazy high and like 20, 30, 40% for these people maybe. That's one downside for that. Number two, the reality of trying to keep someone in quarantine and bubble boy status for a year, and why I say a year is because that's probably going to be how long it takes before we get our vaccine. Can you really logistically take someone and bubble boy them, especially older people? Who's going to change them? Who's going to do all this stuff? Can you really, especially in societies that have a lot of old people, make that happen? I doubt it. Just based on how everyone is doing stuff around the globe, I doubt that could be kept up for a year. Yeah, it would open up the economy. Yeah, it would do whatever stuff. But I think you're trading the devil for the devil you don't kind of thing. And I personally think that's another bad reason. The number three reason I think is because of the severity and the kind of the scale and the slope of how fast things are going. Now, in a certain place, I would say, yeah, Greg mentions people with diabetes. And again, Lisa mentioned young doctors dying in China and the viral load. Yeah, again, so I think there's a lot of stuff we don't know about this disease. And again, why are so many doctors getting sick and dying? Why are so many EMTs getting sick? Why are so many? Because again, my theory is a little bit of viral load thing. You're getting a whap in the face. So you have to be careful about how you roll out something like this. And again, theoretically for me, if you had a very spread out population in a very sparsely populated country, like that lived in a desert and there weren't big cities, technically having a herd immunity thing would not be bad, I think, because you wouldn't overload a healthcare system. But in a New York City, in a London, in a Tokyo, do I think herd immunity would work? Absolutely not. Because what are we seeing happening in New York right now? The cases are going through the roof, and I'm going to go through some of those numbers in a little bit. So let me go a little bit on an update on Hawaii, because I've been meaning to get to this. Again, I mentioned 90 cases, 1 death. We have the 14-day mandatory quarantine. Starting yesterday, stay at home, except a bunch of essential activities and work. And again, they're tracking you on an agriculture form. When you land, you have to self-quarantine. They'll be following you, and it's a $5,000 fine and whatever, and a possible 1-year jail sentence. I've yet to see anyone that will be ticketed for this. I haven't even heard of it, kind of like with jaywalking tickets. It sometimes may happen. I don't know how much they'll enforce it. But I'll tell you, Hawaiians are taking stuff into their own hand. There's a viral clip going along. Some tourists were going down the road to Hana on Maui. It's some scary stuff, man. Some Hawaiians blocked it off, and they're like TikToking it and showing them like banding together to keep tourists from going down the road to Hana. They don't want people coming into their isolated community of Hana. And then I think Governor Ige and other people had to officially put, real cops there or blockades. They blockaded the beaches. I mean, Hawaiians are having some fun with it. They're starting to go vigilante, and not in a violent way, but Hawaiians are very protective of the land. This is just one reason which they're going to try to keep more and more people out. One thing I should note, some of Hawaiian industries are taking stuff into their own hands. One of the things is Hawaiian Airlines, for example, canceled all of their flights. They canceled all their flights, and they weren't told to, but they did the right thing because one of their flight attendants got sick. and one of their flight attendants got sick, and I don't think that's the only reason, but they refunded everything. I'm getting my flight back. I was supposed to fly to LA March 31st to April 8th, and I'm getting that back, supposedly. I think they're doing the right thing. Again, so some things are allowed. Retail is essentially closed. Takeout, grocery, pharmacy shopping is allowed. Basic needs, all those stuff is allowed. Beaches are closed and patrolled, but surfers are allowed to go out. I've heard even surfers are staying away from each other, 6 feet away. They're not hanging out with each other right by the water. So surfers are starting to get a little aggro because all the breaks are getting crowded too. Everyone's getting stir crazy. And I've heard a lot of the hikes are pretty packed. So everyone wants to hike now. I mean, there are not that many hikes and not that many beaches you could go to where you could get away and actually stay 6 feet away from people. So if you want to in Hawaii, I mean, that's up to you, but I doubt you're going to find anything, honestly. Maybe it's a time to pick up long distance swimming or snorkeling, you know, honestly, and get out there. Get around, kick out with a boogie board if you want to, you know. If you get stung by a jellyfish or something else, don't tell me. Shelly said, we have a lot of chickens in Honolulu. Is that true? Yeah, Lisa, we have a lot of feral, wild chickens, not so much in Honolulu, but all around the island and other islands. So, okay, so let me go into a little bit. Oh, one thing I got to tell you. So Governor Ige has been our governor that's been sort of putting down these things. And one thing that I've been a little disappointed by, our Lieutenant Governor, Josh Green, who I guess is his second command as emergency room doctor, all us doctors have been sort of talking with him, giving ideas, giving other different things. And supposedly now the rumor has been going around that Governor Ige has like sort of told Lieutenant Governor Josh Green not to really be around, kind of the way that Fauci is not around anymore for the Trump things. And a lot of the doctors, I mean, he's allowed to do whatever he wants. He's a governor. I think that's a bad idea. He's come out now, the governor, and said, oh, we're only using the 10 most important people, and that includes General Hara. General Hara is the point person now in Hawaii for Department of Defense. I don't think if you have 10 people and you don't have the lieutenant governor who is an emergency room doctor and is in public health and is talking to all the doctors in Hawaii, if you don't have him here in part of these meetings, you are really messing up a lot as far as I think, you know. Okay, so that's Hawaii. The US update in terms of New York, again, my heart goes out to New York. New York's getting slammed. It's really bad. There's 26,000 cases in New York. That's almost still half of the 54,000 we have nationally. I mean, it's so desperate right now. They're opening up old, closed nursing homes. They're opening up Jacob Javits Center. The Navy ship is there. They're pulling doctors out of retirement who are going to be, maybe we're hearing some of these horror stories out of Italy of retired doctors that are older dying. You know, older retired doctors in America and New York may not be as quick on their feet and do the right things, unfortunately, and may be more at risk just because they're older. So I worry about that. One really interesting or sad statistic I heard was Mount Sinai. One of the doctors was reporting on Twitter, Mount Sinai Hospital, this is only one of the major hospitals in New York, like yesterday had nearly 400 cases, about 393 cases, and 89 COVID cases in the ICU. You know, one good thing I would say about New York and the mortality is that in just New York alone, we're not reaching the mortality rates of Italy. We're reaching only like a 0.8, 0.9 mortality. In all of New York State, I think it's 1%. But in New York City, the really dense area, it's only 0.8 or 0.9%. That's only a little worse than Korea, South Korea. So as much as we're getting overwhelmed by the system, it hasn't reached a point where they've been having so many people die unnecessarily or whatever. We're still at 0.8, 0.9%. I see that as a little bit of a silver lining for New York. And if New York's our bellwether and the canary in the coal mine, as they keep saying, and my theory is it's going to spread west, and it will start to be that kind of thing where the later cities are going to start getting hit, and that includes California and Chicago and even Honolulu. As far as I know, Hawaii and Honolulu may be one of the last states, like we're the last state to join the union, and America to maybe see the effect. Maybe we won't see the real peak until 3 or 4 weeks from now, while everyone else sees it, you know, 14 to 17 days from now. I really don't know. I mean, this is just a theory I have. I have nothing to base this on besides that we're very geographically isolated in Hawaii. Stefan says he got a spam call from Tulsi Gabbard, who again is one of our Democratic senators, that said he was going to have a call with Lieutenant Governor Josh Green tomorrow. Stefan, just so you know, the doctors, we've been talking to Lieutenant Josh Green every Tuesday, and we have a sort of round table group call forum with him. So I've been bringing, not so much me, but the other doctors. So we're sort of on top of it, but we need, Lieutenant Governor Josh Green to sort of take our ideas, and also ideally Dr. or Governor Ige to listen to some of this stuff too, because they're not on the ground. We are right now. So one thing I should say is that, again, California West Coast is still getting hit hard, but not as hard as New York. As I mentioned last podcast, I'm really worried about states that are sneaking up the ranks, like Louisiana. Again, Louisiana, where my brother and my sister-in-law and my nephew are, they are getting a lot more cases and proportionally a lot higher death rate and mortality rate. And again, what do you have in the South? Very obese, diabetic, poor mortality, poor life expectancy people already. Alabama, Mississippi, Louisiana, Arkansas. These are states that I would watch out for, because even Florida, at least they have like maybe a slightly better population in terms of health and healthcare system. But Florida, as you saw, they are really struggling from their lack of locking down beaches and some other things. So we'll see. Again, watch New York carefully, and I expect this to spread west. And I actually don't think the worst will happen again for Hawaii until it hits most of the rest of America. I also do think that Hawaii will be potentially better protected geographically and for some other reasons, but that may be just a false hope. So we'll see. New Orleans just announced they're still going forward with the Essence Fest in July. New Orleans, I think they're going to regret it, and they probably still have time to cancel it because it's July. I mean, we'll see. I mean, I'm not saying this is going to be their Katrina, because I think right now is sort of, in New York, is sort of like a Katrina type thing for the federal government. And again, Governor Cuomo's trying his best, but he said they got 400 new ventilators and he asked for 30,000 more. So even though they got 400 ventilators, he needs 30,000 more. And I would not disagree with those numbers whatsoever. One sad statistic I got to tell you is that, even though the daily deaths looks like it's falling a little bit slightly, it might be a momentary blip. And I don't think that's anything realistic. There's some studies I'm seeing that saying that once someone gets intubated, in other words, a COVID-19 patient gets intubated, then you wonder, well, what is the chance they're going to come out of it? I'm hearing those stats are really low, that if they're sick enough to get intubated to that point, in other words, you already tried hydroxychloroquine or oxygen or antibiotics or supportive care, and then they need to get intubated. Some studies I'm seeing are saying that only like anywhere from 10 to 20% of people who get intubated survive, meaning that if you get intubated, that's not a good thing, because you may have a 80 to 90% mortality rate after that fact. And I've essentially heard that once people code or their heart stops, it's kind of like when we see someone in septic shock. You can do CPR you want, but a lot of times they don't come back. A vast majority of times when people's hearts fail because of viral myocarditis or anything else, what I'm seeing, again, this is all preliminary information. We don't have a lot of numbers, but some of the prelim studies I'm reading are saying that if you're intubated, there's a very not so good chance you come out of that. And if you are getting CPR after being intubated, or just CPR because you couldn't get the vent because you were triaged out of it in Italy or something, then your chances are even lower and lower. And in all honesty, in a normal patient for pneumonia or kidney failure or something else, when they undergo CPR, their chances aren't that great either. Honestly, I have to look at the real stats, but I don't think it's more than 50% half the time. So Greg asked, how do I feel about splitting the ventilator between multiple people at once? Well, Greg, what I say is that sucks ass. I wish you don't have to do it. If we have to do it, ideally we can. But the reason why it's hard to do that, it's not like playing like kind of like what's the word? Like if you're sharing like USB cords, from a plug. It doesn't work that way. The ventilator tubing, one ventilator pushes the same pressure, okay? And you have to set it for a certain volume and a certain pressure, right? and that gets split up among 1, 2, 3, 4. So it gets very complicated because you have to account for the pressure compliance of the lungs for all these 4 different patients. Are they easily matched up? You cannot put a very large guy with big lungs next to a lady with small lungs. You might blow out her lungs, you know? So it's not as easy as just doing it. It would be a good idea, but it's not a great thing. We just need more ventilators. That's what we need. The other problem is that they can technically share diseases, obviously, from that. And the likelihood of continuing a pneumonia is about, you can get a ventilator-associated pneumonia. I think the statistic is like 3 or 4% a day chance. Of course, a lot of these COVID-19, or almost all of them, will have pneumonia already, but the point is you're sharing your own tube, you're gonna be spreading other stuff too. Maybe they have other stuff. Maybe they have something else besides COVID-19 that you don't necessarily want to spread. So I think it's an option. I think it's a very last-ditch option, and I think ideally we wouldn't have to come to that, but I'm telling you, New York may have to figure that out, and we're gonna start hearing some more horror stories out of New York than what I'm hearing. And I don't want to depress you, so I'll stick with that. Let me mention a couple of world updates. So again, Africa, again, I talked about the low rates there, whether it's weather, whether it's hydroxychloroquine use, whether not enough tourists to go there because no one wants to go to, certain of these African countries and are vacationing in Somalia routinely, and other places. They may have lower rates. So that's very difficult to understand why. Germany still shows lower rates, and we're still unclear why that is happening. I've heard a lot of theories put forward. I want to research this more. I have some German friends. The numbers are high. They're pretty high still, but the death rate is still fairly low if you compare it to all the rest of the European countries. And as I predicted, and everyone heard my last podcast, the 2020 Olympics are officially postponed, which I think is an excellent idea. It sucks for everyone. I hope you're getting your refunds, especially my buddy Brian. I hope you got some of your ticket refunds. I think they have to give them to you at this point. Spain, as I mentioned, as you're seeing, and I predicted this a while ago, it's getting ugly there. It's getting ugly. They're having mass graves and mass morgues and gyms. There's been 30% increase in cases. 10% of the total cases of COVID-19, again, are healthcare workers. I really think it's getting close to being the new Italy, but maybe it can avoid it. And one scary statistic, I will put this chart up later, the growth curve for deaths, not for just cases, the growth curve for death cases, not just total cases. If you look at just New York City compared to the state, the countries of in South Korea, Italy, Lombardy, Venice, Milan, Rome, New York is worse. The steepness of the death curve is worse than Italy right now. And that's sad, okay? And that's what makes me most concerned about New York. If you look at the death curve, not the case curve, the death curve for California and Washington, it's actually more similar to Japan, Korea. It's closer to kind of South Korea. So meaning that it's not great, but we haven't hit that real steepness of death curve in California, Washington. So I still hold out hope for a lot of the country that unfortunately we will look at New York's pain the same way a lot of the rest of the world has looked at Italy's pain. If we learn from New York's pain, a lot of the states may, if we keep it at South Korea's death curve rate in that, like, you can think about a 20% incline as opposed to like a 65, 70% incline, or even 70, 80% incline that I'm seeing almost for New York and Italy. That would be great if we could keep it that way. One other last thing I want to mention, we talked about reinfections in China and Hong Kong. Someone asked, do I think, well, can people get reinfected once they get it, and does that mean they get COVID-19 again? Does that mean they're infectious still? What does that mean? I do believe you can potentially get it again, and I don't know whether that means there's a new strain, whether that means you just populated by it. In other words, like MRSA, Staph aureus resistant stuff, you can be colonized by it, but it doesn't necessarily cause an illness all the time. So does that mean that you'll get sick from it again? I don't know, maybe not. Because I think the data is too early. They're just seeing these reinfections. Do I think that means that you can start reinfecting other people? Potentially more likely. I think that's still a possibility. I think it's more likely that you'll reinfect someone than get sick again yourself, because I think at a certain point you may have those antibodies, the IgM and IgG. Again, the stuff I wish we tested for. And now the reason why I want to get into that is I think that we need to look at the IgG, IgM as a potential for seeing and having that be the test that I would like to see everyone get. And then we can see, well, when are they able to go back into the working population, you know? When do we need to worry less that we need to self-quarantine these people? You can say that, well, even if they have the antibodies, again, they can still get other people sick. But again, you can maybe do some things that won't shut down, again, the entire economy. You can maybe tell a healthcare worker that a doctor or nurse that, oh, well, now you have the antibodies, so you can work at least for yourself. You're not gonna die of this, let's say. You still need to maybe do complete coverage and other things, but if we need you, we need you because we don't have doctors, that kind of stuff. Again, that's just a suggestion. So again, I think I'm gonna end there. I was really trying to keep this under 45 minutes, but I've gone way past. I wanna mention again a bunch of the resources that I find fairly helpful. The COVID-19 Facebook Resource Center, number one. Number two, again, the CDC website for general information about what they're thinking about testing and the personal protection equipment kind of guidelines. Although, again, I think CDC and World Health Organization are always, unfortunately, 1 or 2 steps behind. So this is just to know what they're saying and to guide yourself on that. And, I leave it up to you about how you want to protect yourself more. And Medscape news update, again, medscape.com is a great app that a lot of doctors use, has a lot of technical information, a good drug database, and it's a good daily email update that's almost entirely about COVID-19 right now. And again, the worldometers.info/coronavirus/countries. Again, worldometers.info/coronavirus/countries. I know there's another one from some 17-year-old kid that's great, that has numbers, but it doesn't have graphs. And I really like those graphs about active cases, recovered cases, deaths, and a lot of different things, because it's not just about cases, and everyone's freaking out about that. Because at some point, we want to see that peak. And you're not going to go see that peak on charts or that just show numbers. You're going to want to see that, as it comes up and ramps up like an S and we're hitting this, we want to see the end or the top of that S. When we see that top of that S, we're starting to feel a lot better, both from a state and a city and a society. Last thing I want to mention is if you really have to think about it this way, we're all concerned as Americans. I want to just talk about being an American because we're all freaked out about what's happening and why is things so different from New York to California to Seattle, Hawaii. I mean, and this is why is stuff so different from Italy to Germany to Spain to Austria. Interesting enough, Austria, they found one ski resort where one bartender apparently spread it to like 100 to 200 people because they were playing like mouth beer pong at this like après ski place in Austria and like blowing a like tequila whistle. And some guy was sharing it all around. It's awful. Do not share stuff like this. Don't share stuff with anybody. But this one guy spread it to anyone. Anyway, my point is, stuff is so different in America. Just go to a globe. Go to a real map. Take a look at America. Geographically, America is larger, if you overlay it, than all of Western and Eastern Europe combined, and maybe a little bit more. We have something like 300, however many million people. We have way more people than any country in Europe, and I don't know about all of it together, but a lot. So we're gonna have a lot more deaths than Europe. We're gonna have a lot more deaths than Italy, Spain, guaranteed. And we're gonna have more deaths potentially, at this point, if we don't like stop it at New York, than China. I mean, if New York doesn't stop this, scarily enough, by, the middle of next month, from what I'm seeing, in another 14 to 21 days, more people will have died of COVID-19 in New York City than all the deaths in 9/11 and the World Trade Center getting hit. There will be more than 3,000 deaths, which is about how many people died in 9/11. And again, I really hope we don't get to that point. If we do, you know, we have to learn from it. A lot of people, I want to say one last thing to the people that are like, and I was one of those people that said, well, maybe this is just, again, still not the new flu, but, you know, people are dying that way. Maybe we have to learn how to accept some of this. And I would say to those people that we can think about that when we can get past this peak in the big cities. When we can spread out and flatten stuff, we can think about it that way. And we can especially think about it more when we get a vaccine. But we do not have a vaccine. So I don't think it's safe to, why are we treating it like it? Because we don't have the immunity. We don't have the way to accommodate all the influx to the ER systems. And the other flu times we did, those deaths were spread out over months, right? The flu season goes from what, September to April? So that's more than half a year. These deaths in America have only happened in the last, like, less than 10 days, right? So this is a rapid exponential thing. You cannot say that this is just the flu. And it was something that I admittedly thought more back in January, even as late as mid-January, you know, and I wish I had done more. And in a way, doing this podcast is my way to make up for it and to help educate people. So I think that's what I'm gonna leave it on. So Lisa asked, are all people on ventilators also intubated? Yeah, Lisa, by definition, if you're on a ventilator, you're intubated. There is a thing called BiPAP where they put the mask on, and they're recommending people not to be on BiPAP because it's not a good seal and it can blow out air everywhere and you're just blowing coronavirus and COVID-19. So what they're saying, again, the recommendation is that you think they're gonna get that sick, you're going to intubate them pretty quickly. And that's why we're running out of ventilators so easily and why it's so dangerous, because as you intubate people, you're running out of ventilators, you're getting healthcare practitioners sick because they're getting the blast in the face if they're not protected right away. And you'd rather do it in a controlled setting. And other thing is that you're supposed to paralyze them and sedate them completely. Not just sedate them, you're supposed to paralyze them, meaning that they'll be totally riding the vent themselves that way, at least in the beginning. I got to read some other stuff on real critical care, but that's what I'm hearing. So I think I'm going to end it on that because, again, I'm going in an hour, and honestly, it's 9 o'clock here. I need to relax a little before I go to work tomorrow. I have a couple more days. I obviously cannot tell you specifics about patients or my hospital specifics, and I really cannot answer specific questions for, you know, I can answer general stuff for you guys, and I've been trying to give some advice, but man, I gotta tell you, some of you guys have been asking me some crazy wild questions, and I'll answer what I can, but if I cannot answer it for certain reasons, just please respect that. This is my way of trying to answer as much as I can right now. So that's about it, and I will try to be back, maybe not tomorrow, but maybe around Thursday or Friday where there's a little bit more information and I'm getting a little bit more of a breather. But stay safe. And again, yeah, wear your mask, clean everything, and thanks for joining in. And again, you can share this to your friends and making it public. You can have people add me again on Instagram at @thetraveling_MD, Twitter at @thetravelingdr. And again, you can add me on my Facebook page here, obviously facebook.com/thetravelingdr. That's it. Thanks a lot, guys. Stay safe and don't hoard. Again, I'm not hoarding. Please don't hoard. Be better, okay? Aloha.